A DNR means do not resuscitate. For NCLEX purposes, you only need to know what the DNR is. A CMO is something that is very specific to a hospital unit and facility, okay? So DNR means do not resuscitate. I'm from the Northeast, so in the Northeast, we call it a DNR-A or DNR-B. DNR-A for us means that you would treat the patient if they had an infectious process, but if they should die, you'd let them die, okay? You won't resuscitate them. DNR-B for us meant that you would not do any treatment. So if the person had an infection, you would leave them alone. You would not treat the infection, okay? The student mentioned a CMO, and she was hell-bent on there's a difference between CMO and DNR, but a CMO, which is comfort measures only, is specific to a hospital facility. So for the purposes of your NCLEX exam, you need to know what the DNR is, okay? When you go into your specific hospital, they will use DNR-A, DNR-B, comfort measures only. They'll use those other terminologies. So I just want you to know for the purpose of NCLEX, it's a DNR, do not resuscitate, in an oncology setting for the purpose of the NCLEX exam. Everybody understand? Make sense?
Yes.
Okay, I don't want to confuse you. The student did mention that that information about a CMO is in your Pearson book. That is correct. It is in your Pearson book. But for the purpose of NCLEX, you just need to know what the DNR is. CMO gets more in specifics about what type of DNR it is. Okay? All right. So if we have no questions about what I lectured yesterday, I'm going to get started, okay? I'm going to try to get you guys out a little bit earlier. We only have one exemplar left to lecture on. I'm going to do some oncology emergencies, give you about a 5-10 minute break, then we'll come back and do some practice questions, and then I let you go, because I know you guys are probably like, I got to study, but I appreciate you coming to class, knowing that you have an exam this afternoon. I did not expect to see this many students, so thank you for coming, okay? So I'm going to share my screen. And we're going to start with brain cancer. It's the last exemplar that we have in Cell Reg. I feel like I've been with you guys forever. When we talk about brain cancer, there's over 100 different types of brain tumors. Some of these brain tumors can be malignant or non-malignant. What we are going to focus on is on the malignant brain tumors, okay? Because this is Cell Reg that we're talking about, okay? So I want you to be aware of that. I'm not going to give you specific names of brain tumors because you really don't need that for the NCLEX. You need to know how to take care of these patients. All right. So they're primary and secondary brain tumors. Secondary means it metastasizes to the brain. Primary means it's localized in the brain. Some can be benign, some can be malignant. It affects males more than females. So 2 days ago on the news, I told you guys I'm from the Northeast, right? So in New Jersey, there's a town called Colonial, New Jersey. There's a high school there. And they have found a high incidence of students who graduated in the last 20 to 30 years who have developed both malignant and non-malignant brain tumors. They don't know why, because these are fairly healthy people. So they're going to be doing an investigation, looking at the ground, the air, testing the walls to see what's going on. Brain tumors are very rare, okay? Very rare to see. Now, just to refresh your memory, take you back to A&P, I did add 2 pictures about the different parts of the brain and the left and the right side, what it does. You're not required to know that, but just to bring you back to, you know, some of you who have taken A&P probably more than 5 years ago, okay? When we look at risk factors and we're talking about brain tumors, excessive alcohol consumption increases your risk. If you have a family history of any type of cancer, that increases your risk. Your age is a risk factor, but recently in the last couple of years, it's been seen more in younger people starting at the age of 25 and older as opposed to 60 and older. So I'd like to see what the data says maybe a year down the road after COVID, not after COVID, because we're going to live with COVID, to see what those numbers are. Having long-term exposures to radiation also increases your risk. So those of you who work in interventional radiology areas, or you work in areas where there are x-rays being taken repeatedly, your exposure is great. Some facilities do provide a little device that keeps track of how much radiation exposure you have. Once you meet that threshold, that max threshold of radiation exposure, that employee is usually removed from that department and placed somewhere else to work. Okay, so long-term risk of exposure to radiation is one of those risk factors that's not genetically linked, family linked at all. Smoking is always one of the risk factors for any of the exemplars that we've spoken about so far. Also, when I talk about exposure to radiation, you can also think of a patient who had breast cancer, right? The breast cancer was fine. Then they come back with other complaints. They might need radiation because they might have developed breast cancer in the other lung and they might need radiation. Having radiation and then coming back with another cancer diagnosis also increases your risk. Okay. So when we look at different types of tumors, I told you there's over 100. The one that I need you to be most concerned with, they're called glios or glioblastomas. Okay. Those are the most progressive and the most common that are seen when we're talking about cancer. Some can be slow growing, and it seems like the younger the patient is, the more aggressive and faster the tumor seems to grow. The mangiomas usually are due to increase of intracranial pressure, so that has nothing to do with cancer. So this would be called a benign tumor, and that's usually seen in the 40 to 70-year-olds. Okay. The last one on the list is slow growing, but it does not spread. But for the purpose of our lecture, the one you really need to hone in on is the glioblastoma, okay? As you can see from the picture on the right, the skull and the brain tissue is encapsulated in your skull, right? There's no room for anything additional to be in that space. So remember that as I start talking about the presentations that you will see, okay? So when we're looking at clinical presentations, most of the time people will complain of headaches. They'll have recurring headaches. And patients will tend to go to their primary care doctor, and their doctor will treat them for migraines. And they might give them migraine medications. They might give them Botox injections to help with the migraines, and nothing seems to work, okay? It's not until they see more of this clinical presentations that I have outlined here, like they might have difficulty with balance and coordination, right? So it'll start with a headache. Then they might have difficulty where they feel like they have vertigo or everything is moving but them, when it's actually them, they're the ones who are moving, okay? They might have nausea and vomiting with the headache. And a lot of times you think it's migraine because migraines, nausea, vomiting, and a headache go together, right? But then you might see an increase in confusion. So increasing in confusion, remember I keep telling you guys mental status change is the key to let you know something is going on. Confusion is a big thing, all right? As the disease progresses and the glio gets larger and occupies more space, the patient might get a seizure. So you might see a patient in the ED coming into the ED who doesn't even have a history of seizures, presenting with a seizure, okay? As the disease further progresses, they'll become weak, they'll have tingling and numbness in their extremities. They'll start to have some memory loss, some difficulty speaking, remembering words, understanding language, okay? The personality and behavioral changes are also a clue. So I had a 23-year-old patient who did have a glioblastoma. She was totally healthy. When she came in, she was blessing everybody, praying for everybody. And as her tumor grew, she was throwing the F-bomb on a regular basis and telling you where you can go and how quick you can get there. So patients will change. If they're usually a nice, demure, quiet person, and all of a sudden the personality becomes the opposite, That's another indicator that something is wrong, okay? Any questions about this slide? So diagnostic tests. So initially what they do is they take a lumbar puncture. So the picture on the bottom shows the lumbar puncture. They go in using sterile technique to remove some of the spinal fluid. Because usually, like I said, the glioblastomas are seen in younger patients, and they're trying to rule out maybe if they have meningitis. So they're going to test the fluid. And what they're looking for the fluid is, first of all, the fluid needs to be clear. It should not have anything floating in it. They're going to check for glucose in the cerebrospinal fluid. They're going to check to see if there's any bacteria in the cerebrospinal fluid, because they're trying to rule out that this young patient might have meningitis, okay? The definitive diagnosis is the biopsy, and that's the picture on the top left, the stereotactic needle biopsy. So they drill a little hole into the skull, and they put a needle in, and they take a sample. Now, sometimes the surgeon will require the patient to be awake. And this is so that you will not touch specific nerve areas to make sure that you're not causing any damage. So they might tell the patient, okay, do you feel any sensation going down your right arm or your left arm? Can you move your right arm or your left arm? Can you move your left leg? Okay, because there's a lot of nerves in your brain. Okay. The other test is the myelogram that they can do, similar to taking the spinal fluid. But the stereotactic needle biopsy gives you the definitive diagnosis. Now, prior to doing the biopsy, they will usually do an MRI, because you need to know exactly where you're going. Is it the frontal lobe, the back, the right, the left? You need to know. So they will do an MRI first to know exactly where they need to go in the skull. Okay. The treatment options are the same as in any other exemplar that we've talked about. Surgery, radiation, chemotherapy, can be a combination of all three, can be a combination of two. Immunotherapy, which has been in the last 5 years, that's where they choose a specific treatment based on your age, your weight, your medical history, because the whole purpose of immunotherapy and the targeted therapy is to decrease killing the healthy cells so that the patient will have less symptoms, okay? Sometimes they will do just a watchful waiting, especially if the glio might be a slow growing one, as opposed to an aggressive one or growing really fast, okay? So what you need to be concerned with, for me, is the craniotomy and what your role is with the craniotomy. That's when they go in, they cut a part of the skull out, and they have access to the brain so that they can remove the tumor, okay, if it is operable. So in the prior slide, I showed you all of the ways that you can treat this kind of cancer. Sometimes they will do surgery first. Sometimes they will do radiation first. Sometimes they'll do chemotherapy first to shrink it down. Or sometimes they'll just go in and just remove the tumor first and then treat with radiation and chemo, okay? It is imperative for you to know, as the nurse caring for this patient in the pre-op setting, that you know their mental status prior to having surgery. So if they have a glioblastoma, you need to know they're awake, alert, oriented before. You need to know their neuro assessment. So remember, we taught you cranial nerves at the beginning. You're going to do cranial nerves, your neuro exam. Okay. The psychosocial history. A big part of the psychosocial history, and I want you guys to write this and underline it and do whatever you need to do to remember it, is health literacy. It is very important, health literacy, to know how the patient learns best. Because no matter where you are, you're doing oncology, hematology, you will always be doing teaching. You will not only be doing teaching to the patient, but you will be teaching the family. So it's important to ask the patient, it's okay if you say it this way. How would you learn best? If I gave you a pamphlet, would that be sufficient? Or would you prefer a picture? Or would you prefer me giving you a picture with an explanation? Or would you prefer just writing what I'm saying and then asking questions? Okay, health literacy is very, very important. Okay, if they have a support system, right? You want to know if they have a support system. That's also important. Okay, their vital sign trends. What is their baseline vital signs? Because all of this you're going to be assessing over and over again in the postoperative phase after surgery. Okay, so post-op mental status. So if the patient has a glioblastoma and they were confused before they had the surgery and they're confused after, that is their baseline. Okay, if you have a brain tumor that's not cancerous, it is more benign, and it's causing increased intracranial pressure like we talked about before, the mental status might be initially before surgery, confused and disoriented. And after surgery, they're completely alert, oriented, and with it. And that's because you've removed the tumor, which decreased the pressure on the brain. Does that make sense to everybody? Then we talk about the head and neck has to be in a neutral position immediately post-operatively. The head of the bed cannot be more than 30 degrees. Because if you think about it, the spinal fluid goes along the spinal column and up to your brain. Your brain has been opened, you've lost some spinal fluid. If you sit that patient completely up, they will have a severe headache, nausea, and vomiting, and you want to avoid that at all costs post-operatively. Okay? Post-op in the PACU, you're going to be doing neuro checks. Neuro checks in the recovery room, right after, immediately after surgery. We'll start off every 15 minutes and then every hour. When the patient gets to the floor, you will initially be doing it every 4 hours, and then it'll progress to every 24 hours as the patient improves. Okay? Vital signs are very important because you need to see the trend. We've just took out part of somebody's skull. We've manipulated everything in their brain. Remember, you have the pituitary glands and the other glands in your brain that help control your sugar, your thyroid. Remember all that way back from A&P? Okay, so that all regulates all that stuff, so it's important that you're aware of that. Pain control is important, right? NSAIDs should not be the drug of choice for pain control. You do not want this patient bleeding in their head immediately post-operatively. Okay, so NSAIDs is a poor choice. You need to monitor the electrolytes and the blood glucose, right? So that's where you have to look at the intake and the output. That's very important for you to look at, because the electrolytes that could go imbalanced could be your potassium, could be your sodium, could be the sugar, right? A lot of times these patients are given steroids post-operatively to help with the shrinking after the edema that's caused from the surgery. So when you give a steroid, the sugars can tend to fluctuate, right? So it's important to monitor the blood glucose. The incisions are usually open to air, and it's usually staples. Do not be surprised if it's the frontal lobe where the craniotomy is done, that the patient might have bruising in the forehead, or they might have swelling or bruising around the eye, or they might have some periorbital edema. That is normal. Okay? And ice is the best thing to use for that. So it's important for these patients to remain hydrated, right? Any questions about this slide?
I have a
Maybe you have
question.
a question? Yep.
I know you can't do it more than 30, but can you just lay them flat, or do you want them to be a little up? Or
You can lay them flat if you like.
okay.
It's usually good to start them off flat.
Mm-hmm.
Because remember, in the recovery room, it's airway, breathing, circulation,
Right.
right? So you need to monitor that airway. Then slowly you can lift them up, but no more than 30.
Okay.
Okay. Because you've displaced so much of the spinal fluid, you know, and the body has to reproduce that spinal fluid, and it takes time for that to happen. So that sudden change in pressure of the amount of fluid that's circulating in your spine to your brain and back and forth, that's the reason why we have to leave them down. Does that make sense?
Yes.
Okay. Anybody else have a question?
Yes, did you say we're monitoring the I and O as well?
They're monitoring the eyes and nose, yep. Because remember I told you about the glands that you have in your brain, taking you back to AMP, your pituitary gland, right, can be manipulated if the tumor is near the pituitary gland. And if that's manipulated, it can cause issues with your blood sugar. It can cause issues with your sodium. Okay.
It can cause diabetes insipidus. I have a pituitary tumor. So your pituitary gland, if stuff presses on it, it can also have like a stalk effect where it releases like all kinds of hormones like prolactin and like thyroid stimulating hormone and like all kinds of stuff.
Anybody have any questions? We good? So now I have a question for you. If this person is constipated, what are your concerns?
Straining because it'll increase intracranial pressure.
Correct. So they have to be on a stool softener and a laxative. Because remember, we cannot use NSAIDs to help them with their pain. So our option would be an opiate, which can cause constipation.
Right.
And the fact that they're not moving. Everybody good?
I might have missed this, but why can they not have NSAIDs?
Why don't they have what?
NSAIDs?
NSAIDs cause bleeding. So you don't want to any post-op patient, you don't want them to have NSAIDs. NSAIDs increases their risk for bleeding. Now, since Ms. Rivera mentioned that she has this issue, you do not need to know diabetes insipidus. I just wanted you to get a general understanding of why it is that you have to monitor those things. Okay, so you do not have to get in detail. My job is to teach you how to care for the patient, okay? All right, so we're gonna go into oncology emergencies. We talked about colon cancer. So with colon cancer, patients can have multiple resections of the tumors, which can lead to them developing scar tissue or adhesions, which then causes the colon to collapse on each other, and then the stool can't go down to the rectum. It goes back up, sometimes through the mouth. If it goes up through the mouth, that's usually a small bowel obstruction. You can see these in patients who are also getting chemotherapy. Okay. So these patients usually have to be made NPO. They will need an NG tube. Usually start them on TPN because we want to keep their nutrition up because these are cancer patients. What's the purpose of the NG tube?
Gastric suctioning.
To suction out. What else?
To prevent aspiration.
If you don't feed the patient, you give them an NG tube. Yes, you're taking out what's coming up in their stomach, right? Or from their intestines, but you're also giving the bowels an opportunity to rest, right? So you're not going to feed. That's the reason why you're not going to feed them. The NG tube will pull up what's there so they don't have to vomit it up, which can be gross because I've seen it many times. And you need to rest that bowel. Because if it's an adhesion, you want the bowel to rest so that it can open back up and then stool can continue to pass to where it needs to go, the correct way out. If someone has a colostomy, they can still get a bowel obstruction. So I want you to be mindful of that too. Okay. Hypercalcemia. I think I beat this to a pulp since I started lecturing to you, right? Usually seen in metastatic bone disease, usually caused from breast or lung cancer or bladder cancer. That's where the calcium in the bone comes out and it goes into the bloodstream. So it becomes serum calcium. And the cancer cells go into the bone. So I'm going to take you back again down memory lane. If the serum calcium goes up, the potassium goes down. So a lot of the signs and symptoms that you see on this slide is a combination of the serum calcium going up and the potassium going down. Usually they will manage these patients by giving them hydration of normal saline, or they'll give them biphosphonates. The biphosphonates will allow the calcium to go back into the bone. Sometimes it works, sometimes it doesn't. Okay. Pericardial effusion. You see it in lung cancer, breast cancer, if they have metastatic disease to the chest. When I say disease to the chest, you can also think of bone cancer because your rib cage are bones, right? So you have a little bit of fluid that goes around your heart. That's normally there in the pleural space, okay? But if it increases, it makes it harder for your heart to pump and produce more blood to go into circulation, okay? So the patient might complain of shortness of breath, or you might see classic symptoms of right-sided heart failure, which is something you learned this semester too. So you see how everything comes full circle. Right, so right-sided heart failure, you'll see the edema, right? They'll be fatigued. They might be short of breath. And usually they treat this with just going in and draining some of the fluid from around the heart. Pericardiocentesis. They take a needle, go into that space and pull the fluid out. Spinal cord compressions you usually see in spinal cord and brain, so that's why I added this slide in. Remember brain, you're always going to think of neuro, okay? So numbness, tingling, weakness with your gait, okay? Loss of bowel and bladder. If you see loss of bowel and bladder and the patient came in and they were able to control their bowels and their bladder, that's a problem. That's a big problem. That's a call to the doctor. That is a, oh, not let's wait and see. Okay. And you're going to be looking for the back pain, the unsteady gait. They lose sensation, some people to hot and cold. Okay. They manage this usually with giving patients steroids. Or they have surgery where they go in and put pins and rods, because when you think of bone cancer, think of Swiss cheese with the holes in it. Sometimes that's what it looks like on a radiology report. So they'll go in and put pins and screws, especially if it's in the back, to separate those discs. Okay, and give them some support. Superior vena cava syndrome. You'll see this in lung cancer. You might also see this in breast, because this involves the lymph nodes, right? You remove the lymph nodes, you remove the filtration system. So superior vena cava, that's your heart, right? Vena cava, close to your heart. So you'll be short of breath. You'll have some edema in your upper extremities. You will see altered mental status, because the edema will go from the upper part up to the brain. It'll cause cerebral edema. So that's where you'll get the altered mental status. They might have edema of their neck, their face, and their eyes. They'll become tachycardic because their heart is working harder to get all that fluid out. So sometimes I have to go in and put a cardiac stent in for these patients while they're getting chemotherapy treatment. And again, steroids. SIADH, brain and lung cancer. You have fluid volume retention and vasoconstriction. Again, you can have altered mental status change. They can have some edema, fluid volume overload. So here you need to restrict fluids. And the physician will let you know, patient can only have 1 liter of fluids for 24 hours, or 1,500, or maybe only 500. So in any disease, you're always looking to find the cure, right? In oncology, when we're talking about cell regulation, a cure is possible, but not for everybody. Okay, so the treatment goals and strategies depends on the type of cancer it is and the patient's overall health at the time of the diagnosis, and the wishes of the patient and the family in terms of pursuing treatment or not pursuing treatment. Okay, so the goals for all can be curative. From a provider perspective, it's always to cure. From a nursing perspective, we want to control the disease and manage the symptoms for the patient. And I always say, being an oncology nurse for more than 20 years, every patient who gets a cancer diagnosis should automatically see someone from palliative care. Palliative care should follow that patient from the beginning to the end. Palliative care helps the patient understand what is going on with their disease. They also do symptom management in conjunction with the oncologist. They're the ones that have the come to Jesus conversation. And when I say come to Jesus conversation, I mean, so you have this disease that has now spread to several different locations. What is your goal? What is your goal? What are you looking to accomplish? And that's the conversation that's usually had in palliative care. Okay. Palliative care also helps the families and the patients if they don't have living wills, a will, someone's a healthcare proxy, at the start of treatment. Say, these are things that you should have in order. I can help you get those together. Okay. This makes it much easier on the patient and the family so that they can focus on going through the treatments instead of, oh my God, I have no. Okay. Does that make sense to everybody?
Yes, it does.
The Wi-Fi is starting to act up again. So if you see my picture go off and on, it's not me, it's the Wi-Fi here at school. Does that make sense to everybody?
Yes.
Yeah?
Yeah.
Okay. Anybody have questions about brain cancer? No? Okay. Let's take I'm only going to give you 5 minutes because I know a lot of you want to get back to your studying. And we're going to do some questions. I created 2 next gen questions, the best I could at 10 o'clock last night, so that you can have an idea and have a chance to take a look. Let's meet back in 5 minutes. I'll stay on if anybody has questions. Okay, guys, gonna start in 1 minute. Everybody's back? This is where I'm gonna need to see you so you can participate. I'm giving gift cards away today. I gave 2 away this morning already. So the answer you're gonna put in the chat to the questions. The first one to respond with the correct answer will get the credit, okay? I'm gonna be in my office, those of you who are coming in my office till about, I think 3 or 4 today. So if you do get it and you're here today, you can come by and pick up your gift card. All right, everybody can see my screen and I can hear everybody, right? First question.
Yeah.
So I'm gonna have to look in the chat. Y'all are too smart.
See,
Okay, it is that person's name I cannot pronounce. She's gonna kill me.
I'm not Renatio Banks.
Thank you for not killing me. If you want to take screenshots or pictures of the test questions and the answers, feel free to do so. I don't care. Just let me know if you want me to go back to the question.
Please go back to the question.
Yes,
Okay.
please.
Thank you.
You're welcome. Can I move forward?
Yes.
Okay. Anybody need to screenshot this or take a picture of this? Yes, no? Moving on. Question 2. I don't answer already. Everybody screenshot? Yes?
Mm-hmm.
Y'all want me to go back to the question? Miss Banks, you ain't playing today, huh?
No, not at all.
So many of y'all responded. I can't even figure out who did what first. All right. Miss Hunt. Miss Hunt? Do you see why that's the correct answer?
Yes.
Yeah. Right, so it's a 21-year-old patient. Remember, I talked about this in the pre-lecture. Vaccines, and I talked about HPV. All right. Ms. Rivera. If anybody got this wrong, I'm gonna find y'all if y'all in the building today. Good job, guys. Number 5. Which statement by the patient indicates teaching was effective? Ms. Hunt again. Ms. Hunt, I don't think I've ever got to see your face.
I'm here.
Tell me when I can move on if you guys want to take a picture.
Could you go back to the question real quick?
Yep.
Could you explain why D is not correct? Because in the example yesterday, they were like not feeling well, and you said that they should skip chemo.
They should, that case study yesterday, they should not have chemo because they were neutropenic. Their counts were low.
Okay,
Yeah.
so like their labs indicate exactly.
Yep.
Low. Okay.
Yep.
Thank you.
No problem. Six. Who put C first? Can't see. From here. B. C. The first C I see is Stephanie. Why'd you guys put B? I'm curious. Why'd you guys put B? Why'd you put dry skin? Nobody? Okay. I'm moving on. Seven. Select all that apply. Elizabeth, you got that one. Does it make sense?
Uh-huh.
No? Somebody said no. What don't you understand? Speak to me.
Why was A wrong?
Reno. The person is post mastectomy for external beam radiation to the left chest and the left breast. They're going for radiation. This is all about radiation,
Okay, I just thought maybe it would,
right? Remember external radiation, they get the tattoo, they go in 30 seconds, they get zapped, and then they go home and they do it for a couple of weeks. So you're
Right.
more worried about skin, right? Because they can get burns.
mm-hmm,
Cardiac, because you're radiating very close to the heart. And respiratory, you're very close to the lung. Remember I told you in that presentation, location, 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 where the radiation is being given to the patient. That's what's important.
okay.
And
All
why
right.
wouldn't it be C?
Musculoskeletal, if we're talking about radiation, we're not talking about just doing a general head to toe assessment. We're doing an assessment for a patient who's getting radiation therapy. Musculoskeletal, we want to do that, but the three that are most important, musculoskeletal is not relative because we're looking at radiation only. You got to read the question and look at what the question is asking. Don't add what you know. That slide I gave you said location, location, location. Now you would do musculoskeletal if they were getting radiation in the lower extremity, right? You would do musculoskeletal. Does that make sense?
It does. Thanks.
Okay. Somebody wants me to go back, or is that an old message?
Old message, sorry.
That's okay. Okay, 8. Caring for a patient in a medical oncology unit. Who do you see first? Miss Stephanie. D, the choice D. What defines a fever? Anybody?
100.3,
100.3 or higher, right?
right.
Remember I talked to you about this for respirations for a lung cancer patient. Normal is 12 to 24 at rest and with ambulation. Remember I mentioned that? So if you have a patient with lung cancer with respiration of 32 with ambulation and at rest, that's a problem. Miss Stephanie, you are on a roll. So some of you put engage in aerobic workouts for 2 hours. No, you wouldn't do that. Start working earlier and complete before it drops. No. you're going to keep all the items used very close nearby to help decrease the fatigue so that the person can continue to work. Remember, I talked about that? Do you need to take a picture of this? Can I move on?
Mhm.
Okay. I forgot. Okay, Andrew. Thank you for your honesty, Andrew. This is a bonus one. I'm going to go back. Andrew, you said you got that one first?
The last one.
The last one?
But I thought the intro-
Okay. I'm going to give you credit for that one then.
Okay.
And then this one would be Aubrey. Andrew got this one. So Andrew, are you in the building today, Andrew?
I will be for the exam.
Okay, stop by and see me. You get your $5 gift card. That's the bonus question because I said on my exam, I'm not going to ask specific foods. So good job.
Oh, wait, I didn't get this. I didn't get this
You
one.
didn't get that one? Who got that one? Aubrey? Bennett? Who's Bennett?
Yeah, that's me. I guess,
That's
but I
you.
was just,
Are you going to be in the building today?
I am.
Okay, I'm in 657. Come see me to get your gift card.
Sweet love. Thank you.
Sweet. Okay, I'm gonna need you guys to help me out. Who's the first person to put something down here? Y'all all went in real quick. This is where I need your honesty.
It looked like it was Stephanie.
Stephanie,
Yeah, but I got it wrong. I put B.
who put C? Nobody? Nobody gets this one? No. Okay, Miss Erica, after I say the answer, you put C?
I'm driving.
I'm driving. Don't tell me you're driving and in class. I don't want to hear that. All right, so you do your admission assessment on a patient diagnosed with colon cancer. Which cue is of the greatest concern to the nurse? Sometimes I see some blood in my stool after a bowel movement. That would be most concerning. That means they're bleeding somewhere. This has to be in order, right? So I should have more than one answer. Ms. Banks, you got this one.
Wait, could you explain a little bit about that last answer?
Sure. I'm so excited somebody's asking me a question.
So yeah, I
In what order?
no
Go ahead.
idea. Sorry, go ahead.
Say that again.
I have no idea like how to start to know
The
about this
answer.
answer. Yeah.
Okay.
So how would we work through this?
So if you get an order for a patient, right,
Mm-hmm.
you would do the lab work first. You make them NPO first. I'm sorry. You make them NPO first. You do the lab work because more than likely they have to wait for the CAT scan because it has to be scheduled, right?
Okay.
And the stool is usually last because one of two things is going to happen. They usually when a patient gets on the floor and they say, oh, I've been having, some bloody stools, it's been diarrhea, it's been constipation, you have to wait to get the stool sample. So it's whenever they can give it to you. Everything else goes first. NPO is first. You make them NPO first. Then you do the lab work. By the time you finish that, hopefully the CAT scan, they can go down to get that. And the stool would be last because the CBC will let us know if they're losing blood. Remember I talked about the hemoglobin hematocrit being low? So it's important that you do that one next. The stool test specimen is just to confirm that they do have microscopic blood in their stool. But the CBC would be a definitive indicator that they're bleeding somewhere.
Okay.
Does that make sense, Gail?
Yeah, no, that helps. Thank you.
Okay. That's Elizabeth. Does that make sense? The suppository not to use?
Yeah, because it's not coming through there.
It's not coming through there. And if they had a colostomy, it's because they probably had the tumor lower down, closer to the rectum. So remember when I showed you the picture with the percentages of where the tumors usually form? So the colostomy, it'll be lower down. You don't want to put anything up there because one, they probably just had surgery. Two, it's not being used anymore because of the colostomy. And three, you can cause bleeding.
Oh yeah.
Oh yeah. I'm making you think, Miss Mia. Aubrey got it. So why are you concerned with crackles?
Fluid excess.
Right. They have the NG tube, but then you have fluid going at 150. Could be fluid overload, no?
Fluid overload, yeah.
This is from a textbook. Can I move on? Yeah. A and B, one answer. Mm. Anybody got points for this one? So the wife of a client diagnosed with a brain tumor tells you, I don't know how I will make it if something happens to my husband. I love him so much. Which statement is most appropriate for the nurse? I will call the chaplain to come and talk to you. That's kind of like putting them off, no? Do you have any family support to be with you? That's a yes or no answer, right? Yes?
Yeah.
Do not worry, everything will be all right. Well, that's rule number one as a nurse. You never tell people everything's going to be all right.
Mm-mm.
But if you say you don't know how it will make you feel if something happens, you're just repeating what the patient said and allowing them to vent. So the patient's asking you the question, you're giving the question back to them, and you're giving them an opportunity to express their feelings. Okay? Remember, all therapeutic communication is not closed-ended. It has to be open-ended. So that's another way of looking at it, okay? And this I got from a little pamphlet that I have with next gen questions. So you might see some more questions like this. Anybody want me to go back and so they can take a picture? Are we good?
We're good.
All right. Mr. Aubrey, you're working your way towards 2, huh? Good job. Let's put the first one. Stephanie, you're saying the last one was you?
Yes, ma'am.
Okay. I didn't put the choice. C. Who said C? Andrew. So let's go back. 67-year-old receiving chemotherapy for lung cancer is admitted to the hospital with thrombocytopenia. What's thrombocytopenia, guys?
Low platelets.
Low platelets. What do platelets do?
Clot.
Help to clot, right?
Mm-hmm.
Okay. So which statement made by the patient when the nurse is obtaining the admission history is of most concern? I noticed that I bruise more easily since the chemotherapy started. Not relevant to the question. My bowel movements are soft and dark brown. That sounds like normal to me. My appetite has decreased since starting chemo. That's true, that can happen, but what does that have to do with thrombocytopenia? Ibuprofen. What class of medication is ibuprofen?
NSAID.
NSAIDs.
Right.
NSAIDs increase your risk for bleeding.
Can I just ask with that, with bruising, wouldn't that kind of indicate maybe an internal bleed though?
Not necessarily. With thrombocytopenia, you could just grab the patient by the arm and they bruise. That doesn't mean they're having internal bleeding. Thrombocytopenia just means that their platelet counts are low and they're at risk for bruising by touching them. You know, sometimes people just walk into a door frame, their platelets are low, they'll get a big bruise from it. But it doesn't mean that they're bleeding internally. If it had said the bowel movement is frank red blood, then yes. Does that make sense?
Yeah, thank you.
Okay. Don't forget, no NSAIDs with thrombocytopenia. I think that's it on this one. So I have 2 more questions that I couldn't put on a PowerPoint, so I put it on here. Can everybody see it?
Yeah.
Okay. So you're gonna have to tell me verbally because, oh no, you can put it on the chat because I can still see it. So for the first one, and it's not a select all to apply, I'm sorry, it's one answer. Elizabeth is correct. Remember I told you guys, if you have a post-surgical dressing for a mastectomy, you have to circle the drainage, put the time. And if you notice that you've done that 4 times in the past hour, that probably means the patient is bleeding from the incision. So you need to call the surgeon and say, you need to come take a look at this patient because you might have to take them back to the OR. Remember I said that?
Yes.
Okay. All right, the second part is post-op day 3, and the nurse prepares the discharge instructions for the above patient. Based on the data below, indicate either A or B. So A means important to discuss at discharge, B, not important to discuss. So in class, when I first tested this question, they said it referred more to teaching. So I told you I just made these questions up 10 o'clock last night. I was tired. So the ones that you picked to discuss, I need you to tell me what you would discuss with the patient. So let's go through 1. Hemoglobin hematocrit, 14 and 28. Is that something you'd want to discuss? Or is that something that's okay?
It's okay.
It's okay.
Hematocrit's low.
Yeah. But you said that's not a big issue before.
Right. It's not a big issue for a breast cancer patient. Yeah, correct.
Okay. Just it's the platelets that are low that are the issue, right?
The platelets are low. So this is a person who had a mastectomy. So you can expect the hemoglobin to be a little low because they had surgery, right? They're post-op day 3. So what about the platelets? What are you gonna discuss? Tell them your platelets are low, or what are you gonna teach them? What is the teaching gonna involve with the low platelets?
No NSAIDs, and then making sure that like if they fall, to get like checked up by their healthcare provider because they could get like a brain bleed if they fall and hit their head. Like just trip hazards and stuff like that. And just concerned about bleeding and assessing for bruising.
Yep, and bruising. What about the white count of 4,000?
Yes, it's low. They're at risk for infections.
Okay, so what are you going to teach them to do at home?
Don't go in large crowds and stay away from sick people.
Animals.
And take their temperature regularly.
Animals.
Fresh fruit and flowers and all that.
The fresh flowers and the fresh fruit they should not have, correct?
No tampons and.
Yep, no tampons. What about people who are just vaccinated? Do you want them around those people?
No.
No.
And no vaccines yourself.
No vaccines, yep. Number 4, what drug is that?
It must be an antibiotic.
Eliquis.
A blood thinner.
Oh.
Very good, Eliquis.
Mm-hmm.
So what you gonna teach them about Eliquis? What you gonna do? You gonna discuss this?
Yeah.
Yes.
Yeah.
Yeah, what you gonna discuss?
I mean, it's bleeding
Bleeding.
precaution, and they have their platelets already.
Keep going. Keep going. What are you going to do? You see there's low platelets. You see there's an order for Eliquis. What are you going to do?
I'm gonna talk to my healthcare provider and
Yeah,
be like,
I'd
yo,
hold
should
it.
we be given this?
You would hold it. Who said hold it?
I did.
Okay. Yep, you'd hold it. Then you'd call, right? You would definitely call and say to the doctor, are you absolutely 100% sure that you want the patient to go home on this? You know this is what their platelets are, right? What
Right.
about the next medication?
It's
Antifungal?
a steroid.
No, guys, you're killing me.
Oh, I'm sorry. I'm skipping a 6. I'm so sorry.
You're killing me.
I missed one.
Number 5. It's in your PowerPoint.
For breast cancer. Yeah, it's used for
Breast cancer. What about
No,
breast
it's not.
cancer? The patient has breast cancer. She had a mastectomy, but what is this drug? What does it do?
It drops estrogen.
Yeah.
Yeah, it decreases the estrogen. So what are you going to teach her? Anything specific you need to teach her? Other than she needs to take this every day because it's going to help decrease her estrogen and decrease her risk for her cancer to come back.
She might get hot flashes.
Hot flashes.
What else?
I like the wheels are turning, even though the wheels are really in another exam right now. Prednisone.
That's steroid.
Yeah, steroid. You care? You don't care?
Yes, care.
Yes,
Yeah,
low
it
white
can-
blood cells.
It can increase your blood pressure and blood glucose. And it also makes you more susceptible to infections because it works by decreasing your immune system.
And you have to wean yourself down and take the whole thing the correct way.
Yep. Good job, guys. All right, this is my last one. I was tired, so if anything's misspelled here, I'm sorry. Oh, that's the one we did. We did this one. I put it on a PowerPoint. Okay, guys. Hallelujah, that is it for me. On Cell Reg. This has been the longest I've lectured. I have to lecture 2 more times, 12 times on the same topic. So those of you who I have gift cards for, look, I'm a butcher. I'm a call Miss Banks. If you're in the building, you need to come see me.
Okay.
Mr. Aubrey Bennett, you need to come see me.
You know, I was
And-
guessing at most of that. I don't know if I deserve a gift card.
Well, if you want to share it, you can.
Sure will. All right.
And Stephanie. So if you're in the building, come and see me. I'm in 657, okay? I'm going to post a little bit more information on brain cancer. I'll put it on a Microsoft sheet and put it up on Canvas for you to look at, all right? If you have any questions related to Cell Reg, put it in the discussion board. The Friday before the exam, do not post no question after 4 o'clock because I'm not looking at it. Okay, I'm trying to do a little self-care. Not looking at checking emails, not doing any of that stuff on the weekend, even though I do it anyway, but I'm trying. Okay? All right, any questions? No question is stupid, no question is silly. Take a look at thrombocytopenia and NSAIDs. You guys are all struggling with that. And platelets. Okay?
Did you say room 657?
657 is where I live with my heater. All right. If you have any questions, let me know. You can shoot me an email. You can put it on the discussion board.